Reminder on this rainy day that we are hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, as well as the Métis chartered community of the Lower Mainland region. And all of you around the province are in your respective territories, remembering the value of that land and the people on it. And also I wanted to remind everybody that March is Kidney Month and yesterday was World Kidney Day. So it's a big month and day for kidneys. And this is the last of our sessions in this month, and perhaps very appropriately. So I'm very pleased to introduce this audience in British Columbia to Dr. William Beaubien-Souligny. He's an assistant professor of medicine at the University of Montreal. He's a practicing nephrologist at the CHUM and a clinician researcher. He's been supported by the Crescent program, which is the Kidney Research Education Scientist National Training Program. And his main research interest relates to critical care nephrology and fluid balance management. And he's a co-creator of something called VEXUS, a novel method to assess organ congestion using point of care ultrasound. And I think that, organ congestion and acute kidney injury are things very near and dear to certainly our hospital-based practice of medicine. So we're really looking forward to your insights, knowledge, and the questions that you're going to ask. So I'm going to hand it over to you, William, and thank you for agreeing to be here.
Thank you for the invitation. So let me just share my screen. I hope everything is fine. So thank you for the invitation. So as said, I will talk today about fluid management in critically ill patients with acute kidney injury. So this is my disclosure. There is no link with the presentation. This is where I practice. It's the CHUM, the University Hospital of the Université de Montréal. It's a spring photo. I need to get me in a better mood because we're waiting for 20 centimeters of snow in the next 48 hours. I want to acknowledge that before this land was called Montreal, it was called AKI by the First Nations of the Haudenosaunee Federation. So I'm grateful that I'm able to live here with my family and work. So here, standard or run-of-the-mill patient that you may see in the ICU, a 61 patient male that had prior chronic kidney disease that is admitted for sepsis and received a large amount of crystalloid during initial resuscitation. And he develops severe acute kidney injury and becomes oliguric, and kidney replacement therapy is initiated. This is a rather common situation, but we must not forget that when there is severe acute kidney injury and that need the initiation of kidney replacement therapy, mortality rate approach 40%, and about 15% of survivor will remain on kidney replacement therapy. And also a significant proportion of survivor will have a significant functional decline. A significant proportion will be frail at follow-up. With advanced kidney failure, there is the responsibility of the clinician to ensure fluid homeostasis. And a critical component of the kidney replacement therapy in this setting is the prescription of fluid removal. And when you prescribe fluid removal, well, there is a clinical dilemma. You're between the risk of persistent or progressive fluid accumulation, and the other side is the risk of intradialytic hypotension. And in the last decade, we have some pretty significant physiopathological data indicated that organ congestion can have some significant detrimental effect. So, of course, we can, as nephrologists, we are familiar with congestive kidney failure related to cardiorenal syndrome. But organ congestion can affect almost every organ in the body, including the gastrointestinal tract, which can contribute to a persistent pro-inflammatory conditions. And maybe also the brain. It's not an organ that we may think that is affected by organ congestion, but there is some emerging data suggestion that it can lead to cognitive decline and delirium in critical illness setting. On the contrary, a repeated ischemia related to intradialytic hypotension can also affect end organs, and it's very well known in the chronic kidney disease population, where intradialytic hypotension is associated with cognitive decline, with cardiac complication, also with a decline in residual kidney function, and also some complication related to the gastrointestinal tract. So on an epidemiological basis, fluid accumulation is independently associated with mortality in critically ill patients with severe acute kidney injury. This is the initial data from the PICAR study published by José Bouchard from the Sacré-Cœur Hospital that has been confirmed in multiple cohorts after that, showing that patients will begin kidney replacement therapy with significant fluid overload would be associated with adverse outcome, and the proportion of days after kidney replacement therapy that is accompanied with significant fluid overload is also associated with adverse outcomes. There is also evidence that point out that patient for which decongestion can be managed may be at improved prognosis. So that this is data from the Renal study, which is a large trial done in the early 2000s comparing dialysis dose on CRRT. And as you can see, survivors tend to have greater negative fluid balance in the first few days of kidney replacement therapy, and this is associated with an improved prognosis. But is this that simple? Can we really infer that patients, as soon as they are started on kidney replacement therapy, we must really remove fluid, and it's really a priority to resolve fluid accumulation? Well, maybe not, because that's all observational data. And one element that may be interesting to consider is in the recently published START AKI trial, which compared to timing of initiation of kidney replacement therapy in the ICU. The patients who, in fact, when we compare the fluid balance in the accelerated strategy and the standard strategy group, we see that there's a quite significant difference in fluid balance at the initiation of kidney replacement therapy. But as you know, in the START AKI trial, there was no significant difference between the different timing of initiation of kidney replacement therapy in regards to mortality at 90 days. Parallelly to that, there is emerging data that suggests that high ultrafiltration rate are associated with adverse outcome in the intensive care unit. So in multiple cohort, the group by Dr. Murugan from Pittsburgh had demonstrated that a high net ultrafiltration rate on CRRT is associated with mortality and may also be associated with reduced kidney recovery. When I was in fellowship in Toronto, we studied whether intradialytic hypotension during the first intermittent dialysis session in the ICU following the transition from CRRT was associated with in-hospital mortality. And it was, despite the adjustment for severity of illness and baseline characteristics. But it was quite difficult to determine which patient will develop intradialytic hypotension in this first session of intermittent kidney replacement therapy. And is there some definitive evidence from randomized clinical trials when, as you can probably guess, there is no clinical trial investigating this particular question? What is the consequence of that? Well, the consequence is that we have, as is frequent in nephrology, unclear guidelines that is left to the interpretation of the clinician. So this is the latest guidelines that is 10 years old on KDIGO guidelines on acute kidney injury that say that you should provide kidney replacement therapy according to achieve the goals of fluid balance that will meet the patient's needs, which doesn't say much to guide us in this setting. That leads to significant practice variation. So for example, we had, this is a large scale survey related to net fluid removal on continuous kidney replacement therapy in intensivist and intensive care nurse that showed that even in the same continent, there was some significant variation in the initial net ultrafiltration rate, depending on the hemodynamic status of the patient in the intensive care unit. And we recently done a survey with, there is some preliminary result here that show that for intermittent kidney replacement therapy, there is really equipoise here, because some clinician will favor limiting net ultrafiltration rate in intermittent kidney replacement therapy, while others will be comfortable with attempting high ultrafiltration rate in those patients. So what is the way forward to inform how to optimally prescribe fluid balance management in kidney replacement therapy in acute kidney injury patients? Well, it's not really surprising that there's no large-scale clinical trial on this question, because we must remember that it is a complex clinical intervention that has multiple interacting components. So first, we need to make sure that we are able to correctly assess the fluid status of the patient. And we'll talk a little bit more about that in this presentation. It is finding the right target to achieve. But after that, we must have an effective fluid removal strategy and feasible fluid removal strategy that will ensure that we'll have a safe way to reach that goal. One of the problems, as you, I guess most of the attendants right now is clinician. So you probably know that fluid assessment is a difficult job, particularly in a critically ill patient. So there is it's the integration of multiple sources of information, and each of these sources of information may have caveats, particularly, for example, cumulative fluid balance measured in the intensive care unit, which can have a significant source of errors through unmeasured fluid losses, and also fluid intake that they can have significant measurement errors. When we talk about fluid status, there is also some fluid status is an unclear term, because we talking about total fluid, total body water, or more like central venous pressure. So there is multiple components to fluid status that must be considered. And there is a rather unclear sentence that we often say in clinical practice, and I do it also. It's intravascularly dry but fluid overloaded. What does it mean? It probably means that the vascular permeability is significantly affected, or that there are significant third spacing involved. But all this is a complex topic, and probably that there must be integration of multiple clinical information to really have a correct assessment of fluid status. So in nephrology, we tend to study also patients with chronic kidney disease, of course, and there has been some development about tools to better assess fluid status in chronic kidney disease, such as the use of electrical bioimpedance technology or blood volume monitoring that is integrated in the hemodialysis machine. I did a recent meta-analysis on the subject, proving that right now those technologies that does not have a clear proven clinical benefit to be integrated in the care of all patients with chronic kidney disease. But in the setting of critically ill patients with acute kidney injury, we must remember that those technology might not hold up. For example, electrical bioimpedance technology might not be appropriate in critically ill patient that might have pleural effusion, and that are prolonged, that are in prolonged recumbent position, that alter the assumption of electrical bioimpedance. And by the same token, blood volume monitoring that are integrated in the hemodialysis machine might not be appropriate, may not predict as well intradialytic hypotension during kidney replacement therapy in the intensive care unit, since relative absolute blood volume might be very different from patient to patient and from in the same patient from different day. So I will spend a little bit more time talking about how maybe point of care ultrasound may help us to assess fluid balance management in critically ill patients who have AKI. And why point of care ultrasound? Well, point of care ultrasound has emerged as a new way to assess, to complement physical examination. And right now, point of care ultrasound is widely available in the intensive care unit. And for the nephrology community, what is lacking right now is mainly the skills to use it, but it's getting more and more common as we in the last few years. And when we think about fluid management or fluid assessment and point of care ultrasound, we often think about inferior vena cava ultrasound. That's what is pictured on the screen here for determining central venous pressure. But the problem is that inferior vena cava ultrasound is a crude marker of central venous pressure. This is the last guidelines from the American Society of Echocardiography. And you see, this is what the echocardiographer will told you when assessing central venous pressure with echocardiography. And you see that the classification is rather crude. So usually inferior vena cava ultrasound can differentiate between low or normal central venous pressure and high central venous pressure, but it cannot tell you whether the central venous pressure is moderately high, for example, 10 millimeter of mercury, or very high, for example, 24, 30 millimeter of mercury. So and there is significant confounding factor in the intensive care unit, for example, the use of mechanical ventilation, or the presence of elevated intra-abdominal pressure that can modify the dimension of the inferior vena cava. So it can be a crude markers. For example, this patient with significant respiratory variation in the diameter of the inferior vena cava are less likely to have some congestive organ injury. But for this patient that have non-collapsible and dilated inferior vena cava, we really it's unsure whether this elevation of central venous pressure will result in a congestive kidney injury, and we need some additional assessment methods to determine if this congestion is significant. Another way to assess organ congestion using point of care ultrasound is to look at a lung ultrasound. That's something that have been studied in chronic kidney disease patients. And it is a rather simple technique, although in the initial studies in dialysis patients, a clinician researcher tended to use the complicated protocol, including 28 lung zones, which is really time consuming, that have been simplified for example, the assessment of 4 lung zone total that may be relatively comparable to the more complicated protocols. So this is an example of what a lung ultrasound look like. So you see here a clip of a normal lung ultrasound. There is the pleural line, which is the first hyperechogenic line that you see moving with the pleural sliding. And then you see some normal artifacts that are called A lines that are equidistant from the surface of the skin to the pleura here. This is normal artifact created by the reverberation of the sound. And these are B-line artifacts. These are vertical artifacts arising from the pleura and getting to the bottom of the screen and moving with respiration. And these are suggestive of increased lung density in the first millimeters of the lung after the pleural line. The problem is that compared with, for example, the use in chronic kidney disease patients, in critically ill patients, there is multiple confounders to the use of lung ultrasound. For example, in patients who have ARDS or viral pneumonia, notably a COVID pneumonia, or even diffuse bacterial pneumonia, these B-line artifacts can arise. And it becomes very complicated to differentiate cardiogenic pulmonary edema compared with other reasons for the appearance of B-line artifact. So that brings me to talking about a little bit more about venous Doppler ultrasound. So the basic idea is that since inferior vena cava ultrasound is not is a crude marker, we would want to assess the impact, the hemodynamic impact of high venous pressure on the venous circulation using the Doppler ultrasound. So just to remind you that venous circulation is a high compliance circulation compared to the arterial circulation. It has low resistance in normal patients, and it has a non-pulsatile source, but there is variation in right atrial pressure that creates variation in venous return that can be seen if we assess venous Doppler centrally, for example, in the hepatic vein. But if we do venous Doppler in more peripherically, for example, in the renal circulation or in the portal circulation, we'll see we'll lose those velocity variation during the cardiac cycle, and the signal will be monophasic without significant variation. But then what happened when the venous congestion develop? Well, first there will be a variation in the venous return during the cardiac cycle, and I'll talk more about it in the next slides. But there will be also the appearance of abnormal venous Doppler waveform in the peripheral venous Doppler assessment sites. So just to come back to the variation in venous return during the cardiac cycle, well, during the cardiac cycle, there is atrial contraction. After, there is the systolic filling phase, which is created by the dilation of the right atria after contraction, and also by the downward motion of the tricuspid annulus. And then after the systole, the tricuspid will open, and there's a second diastolic phase of venous return. And this corresponds to the phase of the CVP waveform. The systolic phase corresponds to the X descent, and the diastolic phase corresponds to the Y descent. And in the LT patients, usually the systolic phase is dominant during the cardiac cycle. When central venous pressure elevates and the pressure gets very high in the right atria, this systolic phase will gradually disappear. And eventually, when significant tricuspid regurgitation develops, this systolic phase can even be reversed. And that's what we can detect via point-of-care ultrasound. And usually it is detected using the point-of-care Doppler ultrasound of the hepatic veins. So this is, for example, an hepatic vein, and this is the pulse wave Doppler of the hepatic vein. And you can see a normal waveform with the systolic phase equal or superior to the diastolic phase. And then the systolic phase gets lower, and it can even get reversed in the last example here. Now, when assessing point of care Doppler, venous Doppler ultrasound in, for example, the Doppler, the portal vein of the liver, when we can see that in normal patient, the signal will be monophasic without significant variation during the cardiac cycle. And when significant elevation at central venous pressure develops, the signal will become pulsatile during the cardiac cycle. And in intrarenal Doppler signal, you can see an example here of a color Doppler kidney flow. And this is another example in a critically ill patient that demonstrate that kidney Doppler ultrasound is much more difficult in patients with hemodynamic instability. So this is a normal Doppler waveform with the arterial flow at the upper part and the venous flow in the lower part. And you see that in a normal pattern, you have a continuous pattern during the cardiac cycle that becomes discontinuous with a systolic and a diastolic phase, and then discontinuous with only a diastolic phase in the later stage of congestion. And this is that mirrors what we see in the hepatic vein with the disappearance of the systolic phase. And these signs are quite dynamic. So this is an example during cardiac surgery. So during cardiac surgery, we can assess venous kidney flow by transesophageal, transgastric, in fact, ultrasound. So this is an example. So we can get a view of the left kidney in some patients using a transgastric ultrasound. This is an example in a patient with cabbage that had a normal venous flow at first and then developed right ventricular failure, and the flow became pulsatile. And after intervention such as IV nitroglycerin and also inhaled pulmonary vasodilators that improved right ventricular failure, we see the resolved intravenous kidney flow that returned to the normal state. So during my PhD studies, we done multiple cohort study at the Montreal Heart Institute investigating the significance of these signs using point-of-care ultrasound. And we found that these signs are associated with elevated venous pressure, other markers of congestion, for example, NT-proBNP after cardiac surgery. And it's a finding that was also noted in other settings, such as chronic heart failure and general ICU population. And this is data from chronic heart failure. You see that, for example, the pattern of renal Doppler, intrarenal venous Doppler, in a chronic heart failure patient really predict hospitalization or death within a year in chronic heart failure patients. This is the data that we done at the Montreal Heart Institute, showing that when we assess those signs, portal flow and intrarenal Doppler at the admission to the intensive care unit after cardiac surgery, these Doppler anomalies can predict the occurrence of acute kidney injury in the post-operative period. So each of these venous assessment sites may have some pitfalls. For example, for the hepatic Doppler flow, the presence of significant tricuspid regurgitation may lead to a reversal of the systolic phase without necessarily having a significant venous congestion. Similarly, in healthy young individuals with low BMI, we've seen some participants that may have some pulsatile venous pattern on the portal vein, but may not suffer from organ congestion. The intrarenal venous flow can be technically challenging, especially in the ICU, and may be impossible to assess in up to a quarter of patients in the ICU. So that led us to develop what we named the venous excess ultrasound grading system, or VEXUS, that combines the assessment of venous Doppler at multiple sites. You can basically saying that if you have one of these abnormal Doppler signals, you should go and look for another one before saying that severe organ congestion is present. And using our data from a previous study, we assessed that the presence of 2 or 3 severe ultrasound patterns was at a very high specificity for the occurrence of acute kidney injury after the admission for cardiac surgery, after the admission in the intensive care unit. So regarding how it relates to acute kidney injury and the management of kidney replacement therapy, well, we don't have at the moment very good evidence about how we could use those point of care ultrasound techniques to inform the care of patients on kidney replacement therapy in the intensive care unit. But we are currently studying it. So we have a study that is currently finishing, the AKI study, that will document the prevalence of these abnormal Doppler signals in severe acute kidney injury and the associated prognosis. And we have another study that will look at whether the presence of these abnormal Doppler signals can identify patients that will tolerate a high rate of ultrafiltration in the intensive care unit. So this is just a case that illustrates the general principle of this patient after cardiac surgery that had very significant positive fluid balance, and upon which kidney replacement therapy was initiated, and that had significant portal flow pulsatility. And in the following 72 hours on CRT, we've been able to induce a negative fluid balance of 7 liters and normalizing portal flow. So this is a proof of concept observation that maybe the presence of these Doppler signal might indicate patients that might tolerate fluid removal. But is this enough? So even if we have additional tools and we integrate it to better assess fluid status in our critically ill patients with AKI, we still need to perform trials to compare fluid removal strategies. And most clinicians agrees that such trial will be necessary, and most researchers will agree to participate in such trial. Despite that, there was no successful trial that compared two fluid management strategies up to date that has been successfully performed. However, there is some pilot trials in similar situations, but not identical situations that have been performed, and that let us think that this will be feasible. First, the RADAR-2 randomized clinical trials that's been recently published in intensive care medicine, randomized to de-resuscitation strategies and proved that it was possible to induce a significant difference between a study arm in terms of cumulative fluid balance 5 days after randomization. And then you see that in another pilot study in patients with acute kidney injury, but not in on kidney replacement therapy, a restrictive strategy was able to induce a significant difference in cumulative fluid balance 72 hours after randomization. So we developed, we are currently developing a pilot randomized clinical trial, which will randomize patients to a protocol-based fluid removal strategy on kidney replacement therapy. And we had the great pleasure of being funded in the last CIHR project grant funding round. And this is the steering committee. My co-PI for this study is Dr. Ron Wald. And I have the pleasure of working with extremely experienced investigator in critical care nephrology, Dr. Sean Bagshaw, Dr. Renal Bellomo, Dr. Adi Carey from Sunnybrook in Toronto, and Dr. Martin Gallagher from Australia. The objective of this trial will be to determine if a fluid balance target prescription strategy aimed at achieving a neutral to negative daily fluid balance on kidney replacement therapy is feasible and can result in a lesser cumulative fluid balance after 5 days. So these will be adult patients in the ICU with AKI for which kidney replacement therapy will be initiated shortly or has been initiated for less than 48 hours. And we'll randomize them to either a protocolized fluid removal strategy or to usual care for 5 days or until kidney recovery or until ICU discharge. And we compare it to usual care. It's an open label pilot study with a sample size of 146 patients. And the primary outcome will be cumulative fluid balance at 5 days. And we also assess feasibility outcome, safety endpoints, such as vasopressor support and adverse events, patient outcomes, resource outcomes, such as the use of CRRT, and process measures outcomes. But what is the intervention that we propose? Well, we think that for it to be feasible, we need to design an intervention that will be customizable and individualizable for the need of a particular patient. Otherwise, it will be very difficult to obtain the support of the attending clinical team because, as you know, net fluid removal must be tailored to the need of the patient. So the first step, in fact, the intervention is a fluid removal prescription that must be updated every 24 hours that will define a 24-hour fluid balance, either a negative fluid balance or for the patient that for it is contraindicated a neutral fluid balance. And the second step of this prescription will be to make sure that it will feasibly be attained through intermittent kidney replacement therapy or continuous kidney replacement therapy. This is the preliminary template of the prescription that we are designing. So as you can see, this updatable prescription must be updated at least every 24 hours, and the clinician will choose preferentially to induce a negative fluid balance, suggested of 2 to 3% of body weight, or if the fluid accumulation is not determined to be significant or fluid accumulation is present, but at the time the patient is not stable enough to induce a negative fluid balance, then we will strongly advise to maintain a neutral fluid balance to avoid fluid accumulation. So for a patient on continuous kidney replacement therapy, there will be mandated frequent reevaluation of target fluid removal goal, and the fluid removal target will be readjusted if these cannot be safely attained. And for the patients for which intermittent renal replacement therapy is used, well, there will be a frequent reassessment by the nephrology and intensive care team to determine whether the next fluid removal goal is reasonable and whether, for example, increase in the frequency of intermittent hemodialysis, increase in the length of each session, or the transition to continuous kidney replacement therapy is warranted to attain the fluid removal goal. So we don't know if these interventions will differ from usual care. And that's why we want to capture process measure outcomes to determine, for example, if the trial is negative and we find out that despite this standardized prescription template, fluid balance management in the intervention arm is not significantly different from the fluid balance management in the conventional arm. What is the reason for that? Is that most patient was not eligible for a negative fluid balance? In that case, what was the reason for it? Or is that the fluid accumulation was not deemed to be clinically significant? And in that circumstances, what was the clinical tools used by the attending clinical team to assess the fluid balance? For example, if the trial is negative and we find out that there's no significant difference between the arms, when we can in that case say that we must integrate some additional fluid assessment techniques such as point of care ultrasound to the care of these patients. In conclusion, fluid removal prescription in patients with severe AKI is a daily challenge, and we don't have currently good evidence to guide us toward optimal fluid management, but maybe practical assessment modalities will enable to identify patients who will benefit from a rapid decongestive strategy, and we must really strive to perform interventional studies to improve our understanding of optimal fluid management strategies. So I want to thank you for the invitation, and I'm really interested of knowing your question about this topic.
So thank you, William, and I think you've certainly touched on things that are near and dear to everyone's heart, because I think it's the crux of nephrology, assessing volume and knowing when to take off enough and not enough. Are there questions from the audience? I'll just get you to raise your hand or type them in. I mean, I'll start. A lot of your work is in the acute setting, but one could perhaps discuss the fact that most of our dialysis patients are also volume overloaded, and I'm not sure that our assessment of volume, I know it's a challenge that everyone talks about, whether or not there might be some use for this tool as well in a non-acute setting, and what your thoughts are about that, or even in the, so I'll stop there.
Yeah, it's a very interesting field to export those principles to other settings, such as heart failure, cardiorenal syndrome, hepatorenal syndrome, or chronic kidney disease receiving renal replacement therapy. I think the first step is to document in which percentage of patients these signs are present, because I feel like, because I use these techniques also, I look at my dialysis patients and I sometimes look at their portal vein, and I feel like these signs are pretty severe, and except in a selected patient that have very severe cardiac disease, those signs will mostly be absent. So I feel like the prevalence of those signs will be rare in this population, but it will identify patients as at very high risk of adverse outcomes.
That's great. There's a question in the chat, or a couple questions. Dr. Harris, thanks for the talk. Can you comment on the inter-observer agreement of the VEXUS and the difficulty of performing this study versus lung ultrasound or other more simple POCUS tools? Any pitfalls or concerns about the feasibility of implementation?
Yeah, that's a very important consideration regarding point of care ultrasound. We assessed inter-observer variability for the portal vein for the intrarenal venous flow during our study in cardiac surgery, and it was actually quite good. For portal vein, it was actually an inter-rater mean difference of 5% in the pulsatility fraction, and for intrarenal venous flow, it was approximately 90% of concordant classification between observers. But in critically ill patients, with AKI, as I mentioned, the success rate may be very much lower for kidney Doppler. More specifically, it may be inaccessible, sorry, in 25 to 30% of patients. So we are currently investigating other sites of sorry, venous assessments. For example, the femoral vein, which is much more easy to perform. So and might have some improved inter-observer agreement, particularly in patients with kidney involvement.
Do you want to get some water?
Sorry.
Okay.
Yeah.
Okay. And then another question. In the absence of point of care ultrasound and the renal on the blood volume monitoring is not accurate to use, what do you suggest we focus on for ultrafiltration? I think what the person's trying to ask, unless you want to raise your hand, is if you don't have any of these tools, how do you assess ultrafiltration?
Yeah, as I said, I think one of the big research questions for me is how to predict tolerance to fluid removal, because it's one thing to say this patient is congested. The second question is to know whether we can be very aggressive about it and remove a lot of fluid in one intermittent dialysis session, for example. And there's interesting work on this, but the short answer is that it's really an understudied topic, and probably that additional markers will help us inform this. Of course, intradialytic hypotension is a complex physiological phenomenon. It's not just, for example, intravascular blood volume that determine this. You know that there is a vasodilatation, and there is some interesting strategies such as the reducing the dialysis temperature to improve hemodynamic tolerance. But to answer your question, it's an understudied topic, but I think it's very important to find markers to really identify patients who will tolerate rapid fluid removal.
Yeah, the precision medicine of volume removal in the in all venues. Okay, I don't see any additional questions. It's Friday before a lot of people are starting on March break over here as well. So listen, thank you for a really excellent overview, not only of the topic, but also of the physiology, which most of us remember and like, but it's always nice to have a refresher. And I think the fact that people are developing and trying to use tools in a more standardized fashion for clinical decision making, I think is really, you know, and that you're helping to lead and get us the evidence that will help us know which tool to use where is really terrific. So thank you, and hopefully we get to see people in person and perhaps participate in some of these studies as well.
Absolutely, and I hope I will be able with in-person meeting. I hope I will be able to teach a little bit point of care ultrasound to nephrologists in Canada.
Yeah, great. Well, thank you,
Great.
William, and thank you for your preparation.
Thank you.
Okay,
Nice
bye-bye.